Thank you very much, Sheriff, also for inviting me. It's a great pleasure to share this 40 minutes lecture dedicated to the computer-guided bone harvesting approach. I mean, the way we can improve the predictability and the safety of this procedure. I would like to start showing this case that is not a typical bone defect case or soft tissue deficiency case, just to underline one fact, that when we are looking to a case where the hard tissue and soft tissue are present, we are very confident on proposing the patient an implant therapy, because when everything is already there and we are taking care about the three-dimensional position of the implant, then the result will be predictable, short-term and long-term. And these make us very confidential on proposing again this type of treatment to any patient. But on the other side, when we're looking to patients like this, obviously everything is going to change. Also, our approach, our confidence on proposing a therapy here is changing a lot, because here everything is missing. We are missing the bone, we are missing the soft tissue, and even more, we are not going to build up just a volume in this area, but we need to build up also a tissue, a vital tissue that is going to guarantee us the implant osseointegration process and the implant stability later on. So a lot of questions from a clinical point of view are coming in my mind in terms of which type of technique, which type of flap design, which type of how many surgeries I'm going to propose to the patient, and also which is the risk by performing a bone augmentation in this area. So what is confident for us is, for one moment, absolutely not confident anymore. And we have many options when we want to go to build up the bone and the way we are building up the bone. But we have anyway one thing in our mind, which is the predictability of the process. So the predictability of the surgical procedure. So we can start with very poor bone quality, like in this case in the maxilla, and the final result is already there in our mind at the time we see the patient for the first time. And this is exactly the same in the lower jaw. So we know where we would like to go. The point is how we are going to go there, which is the risk on going there. So these are questions that are in our mind immediately when we see a defect or a bone deficiency or a soft tissue deficiency around the potential implant site. Also because the risk of complication described in the literature is quite high, is quite render this case basically unpredictable from such a point of view. And obviously, anytime we have a complication, we have more costs. And so we don't want to have complication. We want to have predictable protocols to perform the bone augmentation, and to have predictable protocols, we need to understand a little bit of biology, just a little bit in this short time I have for this lecture. But we need to remember that whatever we are doing, these two types of deficiency, independently on the technique we are doing, behind this approach, there will be always the same biology. So one biology to build up the bone. In the mouth, the bone is going to be formed through an intramembranous ossification. That's the way the bone is going to grow in the mouth. So any type of procedure is going to end up with the same biological process. So, and this process, which is based basically on vascularization, is based on inductive factors present and also mechanical factors. We need to understand that we can influence quite clearly on the inductive factor when we are using autogenous bone. There's many papers regarding autogenous bone and describe the high potential in new bone formation that has autogenous bone. bone. We know, for example, in GBR, this paper from relatively recent from the Boozer group that shows clearly that the majority of the bone was present by using autogenous bone. Or other paper that are, for example, this paper from Schmidt publishing Clinical Olympus Research in 2013, which is a randomized controlled clinical trial, so high science behind this paper, where autogenous bone in the sinus, which is not a very difficult defect to be rebuilt, but autogenous bone compared to homologous or synthetic or xenograft is going to produce more bone than the other material in the same time frame. In terms of healing. So we know from the literature that autogenous bone is still the gold standard. The meaning is not to perform a sinus lift with the autogenous bone, but the point is, if autogenous bone is the gold standard biologically in the sinus, will be even more in the crest, in the alveolar crest, where the critics or the critical point for bone regeneration is even worse. And autogenous bone, for sure, needs to be used in the right way. What is the meaning? The meaning is that we need to use autogenous bone when we're talking about something that is going to be completely rebuilt, completely rebuild it with a new tissue, that the position of the graft is fundamental. So we need to build up inside the contour and not outside. What is the meaning of what I'm saying? That if the surgical goal of your procedure is to build up over contouring of the crest, such this result of a GBR, where we are in a non-natural form, obviously this is the environment where autogenous bone can work short term but cannot work long term. So we need also sometimes other materials, bone substitute, that supporting better the outside contour compared to autogenous bone. And we are doing this usually when we want to have over contouring of the crest and maintenance of this volume among the time. This is a 5 years, and you see that the implant, which is the tooth 2-1, had the same shape on the buccal side compared to the tooth 1-1. Nevertheless, in cases where we want to build up the bone inside the contour, it means that we are not exceeding the augmentation behind the envelope of the anatomical envelope of this alveolar crest. Then autogenous bone is a fantastic material, very predictable to build up the bone. I use the Curie's approach. As Sheriff said, I'm coming from Curie School. I was there since 2007 to 2011, so I spent there 4 years, and I know very well this type of approach, and I know where it's going to work in the best way. And this is the typical way where it's working very well. Inside the anatomical contours, very predictable, very stable among the time. What cannot work is this type of augmentation, when the autogenous bone is placed outside the alveolar conta, the alveolar anatomy, because in this scenario, many papers describe a lot of resorption in the short term, around 60% in the first 8 months. So autogenous bone is a fantastic material, but we need to use it, to work with it inside the anatomical contour. So anytime we have bony peaks like this one, mesial and distal, can be built up, very predictable. This is 4 months after the Curie's approach. This is 4 years, and this is after 8 years. Absolutely stable and fantastic result. Very, very predictable. Now, when we want to augment or want to treat big cases like this, when we have a big amount of bone which is missing, we need, and to have the same predictability as we have seen in these first cases I have shared with you, obviously we need a lot of bone. We need to harvest the bone in a very safe way, which is not obvious, particularly for those clinicians which has not have been strong trained on doing this, because the retromolar area anatomically is a dangerous area. It's obvious that we have safe areas where to harvest the bone, but then in many cases, the safe area, the real safe area, is a quite small area. And when we want to treat this type of defect, we need to harvest big blocks, because we need a lot of bone to rebuild the defect with the Curie's approach. And then in this case, 4 months later, I place one implant with the GBR approach and then connective tissue graft. And this is the final result before loading the implants, and the final results also from a prosthetic point of view and from the smile line point of view that changed it completely for this patient. And this was the starting point, the base of the crest, very narrow base, very strong vertical deficiency. So to treat this patient, we needed bone harvesting procedure. And we know, probably you see already in some lectures, that the mandibular area is the area where we are harvesting the bone, and particularly the retromolar area or the chin area has been described in the literature. Now, we just concentrated a little bit on the external oblique ridge just to underline one aspect, because this is the area where we can harvest the bone, where usually we are harvesting the bone, which is a lateral aspect of the alveolar crest in the direction of the ramus on one side, in the direction of the mandibular body on the other side. Now, this area is quite easily to be analyzed from a three-dimensional point of view, because it's a buccal shell buccally to the alveolar crest, and then is going in the back into the ramus. The main problem is that it's not a diagnosis in a digital software or in a navigation software, because here it's quite easy to understand which is the limit, which should be the inclination, the starting point, the ending point of the process. And we can really also from an image point of view, underline again which is the area and where should be the incision lines and where not should be the incision line. But we have a fact, we have a strong fact, which is the anatomy, and which is the frequency of the position of the alveolar canal, the alveolar nerve, in comparison to the external cortical plate. And we published a study in 2019 in Journal of Periodontics and Restorative Dentistry on a study performed on 50 patients, living patients. So they're not skulls, they are not cadaver, we're living patients. And in the border between the external oblique ridge towards the ramus, there was 26% of the patient presenting less than 2 millimeters between the outside surface of the bone and the alveolar canal. It means high risk in terms of working position. And we need to remember that many papers, for example, using a Lindemann bore, that underline not overgoing the thickness of the cortical plate in that area, or avoid the apical osteotomy in that area, or, like suggested by Curie, not to go deeper than 2 millimeters. But remember, 2 millimeters could be, in some cases, 1/4 of the cases, also too deep. And looking also to the paper published by Curie in 2015 in JOMI, relating to 3,800 bone harvesting procedure, he reported a low complications rate. That's true, but what is amazing in terms of number is that almost 60% of the bone cuts were apical to the alveolar canal. It means that potentially our incision, that when they are too far distally placed, are going to interfere, or has a strong risk to interfere with the alveolar nerve. And they reported 7.3% of nerve exposure. So, but what really changed completely my approach related to a freehand approach compared to a guided approach was this case that happened to me in 2011. I was working on a freehand Curie's approach for bone harvesting from the retromolar area, and what happened? That the fracture line runs lingual to the nerve. So I had the nerve here. What you see here inside the block in this position is the alveolar nerve that was running inside the block. So the nerve was trapped into the block. And this stressed me a lot, I can tell you. And also, pushed me to think about something different, how we can perform the bone augmentation safer, not speculating on what can happen or speculating on our incision position in relation to the nerve. And this brought me together with a good friends of mine, which is Dr. Andrea Fincato, to develop a completely different approach that was published in 2015 in JOMI. So the meaning of a computer-guided bone block harvesting procedure. So the thing that we can decide all the osteotomy lines in advance before going into the surgical field. And we can decide also how to place the Curis lamina, how to perform the Curis approach in the defect, so that we are going to get exactly the dimension of the block which is needed to perform the procedure, and also the evaluation of the quantity of the bone harvestable in a very safe way. We need obviously a digital workflow to perform this. We need volumetric data acquirement, we need a defect analysis, we need bone cuts digital process, and then the surgical plate development. And here we are going to see a case, a female of 56 years old, that she was suffering of periodontitis that has been treated, and then there was some hopeless teeth that needs to be extracted to re-give aesthetic and function to this patient. But the canine in this case were maintainable. What we can see here after tooth extraction and healing, we can easily understand the horizontal deficiency, but we have also a strong vertical deficiency once we are performing a CBCT data acquirement together with a mock-up. So we need to harvest and we need to build up the bone, not just from an horizontal point of view, but we need also to harvest the bone from a vertical point of view. And what is needed basically in this case is around 28 millimeters. So how we can get these 28 millimeters available? Theoretically, we go in the lower jaw and we imagine how to perform our osteotomy lines in this case. But this is ideally what we would like. And when we are working freehand, then we are going to perform this type of procedure, speculating on the position of our osteotomy lines based on what we are remembering of the CBCT analysis. But what we can do nowadays is to perform digitally the process. So we analyze the case, we select the retromolar area that fits for the required dimension. We are using a so-called cutting planes that are simulating the interface of this cutting plates, not the thickness. The interface, I mean, this part here is representing our osteotomy lines, and the outside projection of these osteotomy lines is going to be translated into the interface of the surgical template, so that we are going to extend to the maximum area the bone harvesting procedure, because we know we are going to stay coronal to the alveolar canal, we are going to stay away from the anatomical structure we want to preserve, and we have a surgical template in our hands. So the other opportunity is to have a complete surgical plan before going into the surgical field. So we know exactly for each segment what we should do to perform the best bone harvesting in a very safe way, knowing since the beginning that we are going to get all the material needed to perform the procedure. So we are going, and here we see an animation and a surgical video in parallel, just to help me to transmit you the concept. So the access to the area is very similar to the incision line typical of the freehand approach, but once we have denudated the external oblique ridge, so when we are seeing the bone, then we are not just speculating on the incision position, but we are going to have a sort of three-dimensional ruler through which we are going to perform the osteotomy lines. Obviously, the surgical template is going to be fixed through an osteosynthesis screw. The template is sitting in a perfect, exactly position which is the anatomical position where has been built it up. And now we are not speculating on where we are. We know exactly where we are. We need just to follow the surgical plan. So we are reaching, we are not just crossing the cortical plane, but we are going at 7 millimeters, sometimes 9 millimeters, or sometimes 3 millimeters. It depends on the anatomical situation. But through this three-dimensional ruler, we can perform the osteotomy lines very easy, very clean. We don't need to be brave surgeon to perform this. We need just to follow what we have decided, what we have planned. So we have each side to be followed. We saw the vertical osteotomy, we saw the mesial one, you saw the apical, or you're seeing the apical one, and then the distal one. Everything is used by facing the flat part of the piezoelectric tool against the inner face of the surgical template. So we are going to perform osteotomy lines which are very precise. We don't need to use a hammer anymore. We don't need to generate any force to create a fracture, because we can bring the osteotomy lines very close to each other, so the patient will not even feel what we are doing, because we are not hammering. So it's a very atraumatic, strong, under control procedure. This is a bidimensional image, post-operative. You see what you can see here. What I want to show you here is that our apical osteotomy is always, anytime, running over the level of cranial to the alveolar canal, as was planned. So what we are doing with this bone, you know probably by other presentations. So I'm applying Curie's approach, building up the buccal wall, building then later the palatal wall with the second lamina, and then placing the particulated material in between. But everything is fitting perfectly because we plan the dimension of the block, and then we know we are very confident on performing the procedure, because we have all the autogenous material available to perform the procedure. Because we are going to see in other cases, we can simulate also how to place the lamina in the digital world. So once we have built up the anatomical repertoire for the lamina following the anatomy, we're placing the autogenous bone particles, and then you're going to close the wound without place any type of membrane. And this is the healing 4 months later. Typical healing of the Curie's approach, where you have a very vital bone, very vascularized bone, and we can place our implants in the perfect position. And if you want, you are in a static area, we can then overbuild the area with some particulated, slow resorbable material through a GBR approach of 1-2 millimeters. So then we are place our implants, and then we wait 4 months more. After 4 months, we need to perform the mucogingival surgery, and then this is the final result. Look, the starting point, the canine is still the canine of the patient with the crown. Obviously, we have an implant on the position 1-2, and an implant in position 2-1 with a pontic in the right central incisor, and then an implant on the premolar. And this is the result after 4 years, everything nice and stable. So the concept, which is the safe cut, this is the safe cut protocol and safe cut concept, is starting analyzing the defect, understand how much bone do we need to perform the augmentation. Then we're going in the retromolar area. We selected the osteotomy cuts, which are corresponding to osteotomy planes, and the outside projection of these osteotomy planes are going to be translated into the surgical template. And this is a three-dimensional pre-op and post-op DICOM data and analysis, and you see that we are perfectly fitting with the surgical template. It means that the surgical template was in the right position, and the osteotomy lines are being performed in the right way. There is a second publication that came out in Journal of Periodontics and Restorative Dentistry in 2017, reporting the first 13 patients treated, And what is interesting is that we talk about also chin harvesting, because on the chin area, we can also perform the procedure thanks to the guided approach, saving the sensitivity and vitality of the teeth, because we can bring our osteotomy lines away from the apex, away from the neurovascular bundle of each teeth. So once again, we can perform the procedure in a very strong, predictable, and safe way. So we are not stressed performing this procedure. We are very confident, there's no stress. We can concentrate ourselves on other steps of the surgery. So everything is done following a surgical plan, following what we want to do and what we need to do to get the bone from the donor site. So the potential benefits of this approach is the safety, is the bone quantity, and obviously, once again, the user-friendly approach, because we can, everybody can do it. We don't need to be brave by doing this. And I want to start with this point and go back then to the safety. So why is user-friendly? User-friendly because, once again, we can have precise osteotomy incision thanks to a very easy position to be found in the surgical field, thanks also to a quick reference point that can be added anytime we have a tooth, thanks to matching the STL file of intraoral scanning with the DICOM data. So we have a very fast and precise position found in the surgical field, and then we can start by performing the osteotomy lines. And then what is important is to bring the piezoelectric tool very flat into the internal face of the surgical guide, so that this guide is going to work effectively as a three-dimensional ruler for the procedure. And this is true for the vertical as well as the apical osteotomy line. So we find the position, we are very flat with the internal face of the surgical guide, and then we proceed with the osteotomy lines. And this is very simple to be followed. Why bone quantity? Why bone quantity? Because the process is completely digitally guided. Look here. So we start with the defect. This is a very critical scenario. We are missing walls. We are missing the recipient side. So what we are doing, we are bringing this in the digital field. We are measuring the defect. We are analyzing how much bone we need. We bring this dimension in the mandible, in the safer area. Then we are placing our osteotomy lines, checking any time to get the right dimension for that. And then we are placing all the other osteotomy lines. Then we translated this into the surgical guide. And then we can pre-visualize also the relationship to the nerve. We can check the block. We can also divide the block following the Curious approach, and then simulating in advance, which is the best way to place the bone block to rebuild this alveolar crest. In this case, with the block on the occlusal side and one on the vestibular side with the lingual side, which is going to stay open. So now we are approaching the surgery, the real surgery, but we know already everything. So we don't need to stop during the surgery to think about what we are doing, because we decided everything. We performed the bone. Look here how precise are these osteotomy lines through the SafeCAT surgical guide. We are performing the osteotomy. We are harvesting the bone in a very safe way, exactly the dimension that was planned. We are going to divide the block into two pieces following the Curious approach. But we have everything in our hand. We had everything perfectly knowing in advance that we are going to get the material, that we will be able to perform the augmentation as we would like to do it. So we have the two lamina, we are scraping them to get in the particulated material. This is the typical Curious approach, but we are starting with a strong digital background. So then we are performing a tunnel approach. We are placing the first occlusal lamina. We are going to have 10 millimeters vertical deficiency. This is with a tunnel approach because the mucosa was very bad in that area. The second lamina, and then we close the wound. And this is the healing 4 months after. 10 millimeters 4 months after, completely regenerated thanks to the power of autogenous bone. We are placing the implants. We can protect this environment eventually with some slow resorbable bone, but look here, this is before loading the implants. There was nothing, and these implants are completely embedded in new bone, vital bone, in their perfect anatomical position. So the bone quantity is a crucial point. Other case, we have 20 millimeters vertical defect in the maxilla. We have 20 millimeters in the mandible, same patient. So we're supposed to have the necessity to have 2 bone harvesting in this area. But what we can do is one block when the anatomy is possible to be performed, one single block harvested from the retromolar area to perform both sides in one procedure. So less invasivity thanks to one side that is going to perform as a donor side, but with the same safety as you have seen till now. So we are harvesting almost 4 centimeters of bone, very, very safe way. And you divided then this block in the 2 lamina, and then you can perform the Curie's approach on both sides in the upper jaw and lower jaw, following the concept described by Curie, but we perform already on the digital field, so we know that everything is going to be fine, everything is going to be okay. That is the meaning, or that has a meaning also in terms of time, because if you know exactly what you want to do, you're going to spend less time by doing. So the surgery is going to be performed faster because everything is following the pre-surgical plan. And once again, here we are around 8-10 millimeters in the lower jaw, around 6 millimeters in the upper jaw. And this is the healing. This is the post-op x-ray, but this is the healing 4 months after. Fantastic bone. Sorry for the audio. And this is then the final results, one side and the other side. These are clinical picture 3 years later. So we go to the safety point, because the safety point is a key point. And we performed obviously a study around this. And this study was based on 25 patients treated consecutively. We asked the bioengineer team of the University of Trento in North Italy to set up a study protocol to an analysis of the pre-surgical and post-surgical CBCT data. And what we have found is that we have a tremendous affordability and safety of the process. Because what you are going to see here that seems really something printed and not something performed surgically. Look how the bone is cutting. Look how the interface of the surgical template is continuing inside the bone exactly as planned. We are going to have a very, very strong precision by doing this. So what we see in the left side, this picture, this schematic picture, and what you see that has been performed surgically is really what we want, is really what was the aim of this approach. And this is the data. These data are still not published, but they are already presented since last year. So we have a median discrepancy in the vertical osteotomy, which is 0.28 millimeters. And remember that we are using a tool which is bigger, almost of the double. It means that your mistake, your surgical mistake, is inside your osteotomy line, which is a minimal amount. And the same for the apical one. And the apical one is a little bit, you have a higher discrepancy, but just because when you are working that area, there is a surgical tendency to bring the cut through a rotation towards coronal. So we are harvesting a little bit less bone than was planned, of around 0.5 millimeters, which is a minimal discrepancy. And this is some example. Look here, the green line is what we would like or what we have planned, and the red dot line is what we have performed. There is a displacement which is around 0.3 millimeters. So we can definitely talk about safety on this type of procedure. And if we're talking about safety, obviously we can perform also those cases which are really dramatic, like the case I showed you before. In this case, we need to understand that the first thing we need to understand, if we're going to have the bone available to perform this procedure. And we don't want to understand this during the surgery. Try to collect some bone on the right, some bone on the left. What we want to do is to do before going into the surgical field, when we are still talking about the patient in relation to the options. And this can be done through the digital world, through the protocol we have developed and also patented internationally. And what is the big advantage? That we can plan everything in advance. Now we know perfectly that we are going to get all the bone needed to perform the procedure, and we know that we are going to do it in a very safe way without affecting the vitality and sensitivity of the frontal teeth and avoiding any interference with the alveolar canal, almost when we are going to harvest the bone, basically in the ramus and not even in the retromolar area or external oblique ridge, because here the external oblique ridge was too small. So we are going to approach this case and we are going to build up the bone completely. So you start with nothing and you are ending with a fantastic final result. This is after 1 year of loading, and this is after 4 years of loading. So we have also a strong stability of the augmentation, and here we build up the bone 15 millimeters in a vertical direction. So it's not a short augmentation. This is a big augmentation, 15 millimeters and 35 mesiodistally. And what we can do, we can treat also those cases which are the result of perimplantitis. Look, this case, the perimplantitis destroyed everything. We have nothing. If you perform a walks-up here, you can see the distance between the teeth and the position of the bone at this moment. But we can go through the digital planning. We can go through a computer-guided bone harvesting with the SafeCut protocol, and with the SafeCut guide, we can harvest the bone digitally. We can place already the lamina in their final position, simulating completely the surgery. And then we go into the surgical field. We are going to perform the bone harvesting. We are going to perform the bone augmentation. Very self-confident on what we are doing with very low level of stress. We can concentrate ourselves on the soft tissue management, on the Curies approach development, but the bone harvesting is something that has been solved in advance. And this is the result 4 months after. Nice bone. We are placing with a digital approach, with a dynamic navigation, the implant, and then we are protecting this environment with bovine bone in a GBR model to protect the bone, the maturation of this bone in the time. And this is before the loading of the implants compared to the starting point. And this is once again at the time of prosthetic loading. Look, these implants are placed when there was nothing around. But this is true for these cases, but it's even help us also in those cases where we have aesthetic impact of the procedure. So we have a very catastrophic starting point. You see here the discrepancy, very big. But what we can do, we can check digitally the position of the teeth and the position of the bone. We can simulate the bone augmentation digitally. We have a surgical plan, and then through the surgical plan, we can go through the bone augmentation procedure. We can build up the bone completely, and we can go then to the implant placement. At the time, look here how changed the volume in this area, and this is the nice result we have obtained after 4 months healing with the curious approach in the vertical augmentation. And then obviously we need to go through soft tissue management because these steps are still needed in these cases. But look here, this was the starting point. This was the starting point. This is with the temporary crown. This is once again starting point, temporary crown. This is the bridge, how it's been built up, preoperative, post-treatment, the smile line of the patient that now is more natural with the new dentition. You look here in the lower part, you see the starting point. We have teeth which are shorter, we have much better anatomy, we have much better integration of our prosthetic rehabilitation to the natural teeth. Look, the starting point that was amazing in terms of discrepancy, once again with a mock-up, with the anatomical aesthetic guidelines that are completely rich in this case, and obviously the gray, black and white aesthetic, which is optimal. So I'm concluding now my lecture, showing, and I hope I have shown you how nice can be the digital world to generate the right bone harvesting procedure, very safe, very comfortable for the surgeon. So I really can say that I'm working this way since 2012, and I would never again perform bone harvesting freehand, not because it's not possible to be done, but because in this way is much safer, much free of stress for the surgeon, is much more predictable because you can check since the beginning if you are able to get all the bone needed to perform the procedure. So I think I finished my time exactly now, 45 minutes. So I thank you very much for your kindly attention, and I'm here ready for answer all your welcome questions you would like to send to me.
Thank you very much for the awesome and great lecture and presentation, Luca. Thank you.
Thank you.
So you are in time. We have no time to answer the questions. I will start. I am going to start. Divya is asking you a question. Can you please tell us steps of guided fabrications?
So the step is you need to work through a protocol, and actually the only way to have it, because I can tell you clearly, this protocol, this patent now is in the hands of Nobel Biocare. So one way is to contact them. The other way is eventually to go through me, through direct myself, and to explain better how it's going to be performed. You need, if you want to do it yourself, now is a quite long work, because you need, if you are working alone on a CAD software, you need 2 hours time to perform it. Otherwise, what we are doing now with many clinicians in Europe is to perform it through a service model. It means that I have my team that can work with the DICOM data anyone can share with us, and through internet, through a remote access, we can plan the case, we can select together the cutting planes, and we are going to design the surgical guide. The final design we are going to share with the doctor, and then we can provide the surgical template physically, or we can share the STL file to be home printed.
Thank you. Thank you. Next question from Ahmad. Did your study include a follow-up of how the donor sites heals in such a clean harvest?
Yes, thank you for the question. Yes, we did it. We have some data we are finalizing to collect. The bone is going to be rebuilt from more or less 60 to 80% of the original volume. It depends on the dimension of the block harvested. Bigger is the block, less bone will be formed. Shorter is the block mesiodistally, bigger will be the amount of bone is going to build it up. And usually we can harvest the second time once again guided among 2 to 3 years to 3 years later than the first harvesting.
Okay, good. That is a good tip. So Burak Hassar from Facebook are writing, "Dear Luca, for me the best presentation was the best ever in this Congress. Thank you a lot. One question. In the case of upper right posterior side, did you use 3 pieces of bone plates? One in the ridge, one in the vestibular side, one in the palatal side, or only 2 by missing the palatal side? Regards, Dr. Burak Hassar."
Yes, thank you for the question, and thank you also for the compliments. I appreciate a lot. There was just 2 lamina. There was 1 lamina on the occlusal plane and 1 lamina in the vestibular plane. On the palatal side, there was just a periosteum given by the tissue, but usually the palatal side is quite a stable environment once you have the other 2 laminas, because due to the very low elasticity of the palatal keratinized tissue. So in many cases, you need just 2 lamina, 1 occlusal and 1 palatal, particularly when you have a flat anatomical base on the defect.
Thank you, Luca. Thank you. Next question from Facebook, Stefan Dominicic. How do you make sure the surgical guide fits perfectly with the bone surface? I understand the threshold management in 3D planning is critical.
Yes. Now, this is a good question. What I can tell you is that the position of the surgical guide is given in a very anatomical particular point. The external oblique ridge is like the border of a table. So it's quite a clear anatomy to be read on a CBCT data. So you usually don't have scatter on that area. And so we have a very cortical thickness plate, which is easily to be individualized on the digital work. And the other point is that we are using tooth reference given by an intraoral scanning. So the surgical guide is bone seated, but has also a tooth reference to be faster on find the position. But the anatomy in that area is so characteristic, which is very easy to find the position of the surgical template based on the anatomy, because it's going to be seated in one place only.
Okay. Okay, Bodan Felix Arion is asking, good evening, very nice guide, but when touching the guide, the tip of the piazetome, we will not lose the power?
No, sorry, I don't understand.
From the piazetome through the touching of the guide, the question is, will not lose the power of the
power? No, look, this is a good point, but at the end, we are going to be faster compared to the freehand, because you have to consider that working with a 3-dimensional ruler, you are going to maintain the working direction of the piezoelectric tool always placed in the right way. So you are not increasing the dimension of the osteotomy lines. You are not working with different angulation during the osteotomy, but you are always effective on producing the right working direction. So thanks to the 3-dimensional ruler given by the SafeCAD guide, you are faster and very precise. So you are not losing potential. in power.
Thank you for the questions. Thank you for your answer. And 2 questions to the software. Which software do you use? Which is it?
There are two softwares. They are underdeveloped by Nobel. So unfortunately, I cannot answer to this.
Okay. Then the next question from Facebook, Prasantan Junja is asking, thank you for the question, sir, please, throw a light on soft tissue. If we perform vertical augmentation of 20 millimeters, how to get soft tissue covering?
Yes, you should ask Sheriff to give me 45 minutes more, and I can tell you. No, I mean, now my focus on the presentation was the computer-guided approach, which is one step of the procedure. Obviously, soft tissue management is another key factor, and we should have, sincerely, more time to discuss about that.
So, okay, next question from the Facebook portal. Okay, Bilal Omarji, all the compliments. By the way, because we have not the time, I searched the questions, Luca.
Yes.
Bilal Omarji, how check the deep of the cut in the bone by the gradation right in the type of the piezo?
Because on the piezo tool we have some tags, like for the implant bore. So it's quite easy to see how deep we are working. So there are some reference points, but so the control is visual, but the advancement of the piezo can be easily controlled. So is really easy to manage this type of working depth during the procedure.
Wonderful. So I check here the question from our last 2 minutes. Okay. Okay, any presentation at harvesting area from huge? Okay, Yağmur Saraç is asking, any presentation at the harvesting area that kind of huge compact mandibular defect? Thank you for inspiring presentation. You saw it. Preparation at the harvesting area, that kind of huge compact mandibular defects.
Any preparation of the recipient site?
Yes.
I have published at the end of last year a systematic review that has been published in Journal of International Journal of Maxillofacial Surgery, which is a systematic review on the needs of perforation of the recipient site. I think that is something that we are doing since 20 years, probably clinically. There is still no scientific background on performing this in human. Now, what is the message? I don't mean that if you are used to do it, you should stop, but you can do it. We can do it if we are thinking that this can help, but there is no scientific background. I mean, there is no scientific meaning on those perforations are bringing to us more bone. This is science. Then we can do clinically any time we want to do it.
The last question from Carlo Escoto teacher. Thank you for the question. How thick are the blocks already divided to avoid breaking when fixing it?
Okay, they are around 0.7 millimeters. I wouldn't go lower than 0.7 millimeters.
Okay. So many questions, the time is over. I want to say something to Luca. In the Curie Clinic time, it was so the experienced colleagues in the 3rd year give some tips and support the new colleagues, and he was one of my mentor in the Curie Clinic. I learned from Luca many things. Thank you.
Thank you very much, Sharif. Thank you.
Italian style.
It was a great
operation.
pleasure. Thank
Also,
you.
thank you.
Thank you for everything, and stay safe, everybody. Ciao.
Thank you. Ciao.